you. Thank you very much. It's actually my delight and honor to be able to introduce Dr. Justice Nonvignon. He's not only a friend and collaborator of great value to me, but he's also a very accomplished person. Currently, he's the technical director and cluster lead for the primary healthcare efficiency, effectiveness section at the Management Sciences for Health, and he's also Professor of Health Economics at the University of Ghana School of Public Health. But previously, he served as the founding head of the Health Economics and Financing Division, Africa CDC, Africa Centers for Disease Control and Prevention, which is an autonomous technical health agency of the African Union based in Addis Ababa, Ethiopia. Dr. Nonvignon has a long history of leveraging research and health economics evidence to strengthen public health programs, including in over a dozen countries in Africa. And he's also advised major global health players, WHO, UNICEF, the World Bank, USAID, and many others. So it's great delight I hand over to him. I'm sure he has a lot of very interesting insights to share with us. Thank you.
Thank you so much, Mark. I'm very humbled. So can I share my screen?
Yes.
It's saying I need to send a request. I've sent a request. Okay. Okay. Share. Please let me know if you can see my screen.
Yes, we see your screen. Thank you.
Okay. Thank you so much, Mark. And for me, it's this webinar is coming back home in many ways. NYU, I have very good friends at NYU. You know, Mark has been a great colleague over the past years. He was very instrumental in the support for my team at Africa CDC during the heat of the COVID-19 pandemic. But also, I have great friends at the College of Global Public Health. You know, Chris, Yasim, Emily Goldman. We had collaborated very, very early on. Well, not very early on, but many years ago, maybe 10, as we discussed and worked on many different things, given the strong relationship between the NYU, you know, College or School of Global Public Health and the University of Ghana. So for me, it's an opportunity to come back home, and I'm happy to share these reflections. Before I go on, I might say from the beginning, even though I might break that promise, that I did not intend to focus this presentation on aid and whether or not aid has worked for Africa. But somehow, some of that may appear at some places. The focus of this presentation really is what can Africa do out of this situation? How best can Africa finance its own health, given the current situation? So this would be the outline of my presentation, and I hope to interact. Background. Indeed, Africa faces not a double burden, as some like to call it, but a triple burden of disease. You know, triple burden. Communicable diseases are not necessarily reducing as we expect them to be. Malaria, HIV, TB, even neglected tropical diseases, you know, are quite high in many countries across Africa. And we are seeing a growing, at an alarming rate, non-communicable disease burden also on the continent. But over the past couple of years, we've always seen emergencies, we've always seen these threats, but in the past 5 years, I must say that we've seen an increase in the emerging and re-emerging threats on the continent. So Ebola, COVID-19, Mpox, and all of them, these adds to the regular cholera and other outbreaks we have on the continent. So indeed, we have big problems when it comes to health. But so do we also have very ambitious plans to tackle our own health. And if you follow the African Union over the past 2-3 years, there has been a lot of attempts to develop plans and programs that will help Africa take charge of managing these different, not just the emerging and re-emerging threats, but also the communicable and non-communicable disease programs. So the, new public health order that some of you may have heard of is basically an attempt for Africa to stamp its, or for Africa as a continent, but also as sub-regions and countries to stamp their own foot and drive their own agenda when it comes to health, and to some extent also financing of health. So these, beyond the new public health order, there's also the Africa Leadership Meeting on Investing in Health, what we call the ALM agenda, which was passed by the heads of state in 2019. That seeks to strongly mobilize domestic resources for health. So some efforts have been made, but we are far from getting where we should be getting. Now, on this slide, I want to focus your attention on the current economic state of Africa. A continent of 3 trillion, which is not a lot. I mean, if you look at the GDP of other countries, 3 trillion is not a lot. But in 2023, the GDP of the continent is almost 3 trillion, distributed as on the map. The top 5 countries, the countries with the largest GDP, South Africa, Nigeria, Egypt, Algeria, Ethiopia, account for 50% of that amount. And on average, this is a hypothetical country called Africa, right? If you do a simple math of dividing, GDP by the total population, that country is not a low-income country. That country is a lower middle-income country with a GDP per capita of at least 2,000 US. But we know that GDP is not a perfect measure of the true wealth of countries. Africa is endowed by a lot, or with a lot of resources, many of which do not find themselves going into GDP, but also many of that's remaining potential and not seeing, its true, not seeing reality, because a lot of these resources are mined, are exploited in their natural state without, any processing. And so they remain quite cheap, significantly underestimating the true resource potential of that continent or that hypothetical country called Africa. So this is where we are, 3 trillion. Please keep that in mind. Health expenditure, we all know that Africa is not spending a lot on its health. On average, this map is from the World Bank's database for 2021. And if you look at the map of Africa, the majority of our countries are spending much less than 7% of GDP on health. I will revisit this percentage when I get to the Abuja Declaration. And then we'll revisit the 3 trillion again. But essentially, we aren't spending as much as we could on health, leaving others to step in, and two main, shall I call them people? Not people, but two main entities have stepped in. One is aid. Look at Africa. The darker red areas represent areas that depend more on aid in financing of health. So again, this is for 2021. We are looking at development assistance for health as a fraction of total health spending. And so you can see that for majority of our countries, in fact, in some places, aid money as a proportion of GDP, or as a proportion, sorry, of total health spending in 2021, you know, is high, more than 40, in some instances, 60% of government spending on health. So aid has played a key role, but also domestic out-of-pocket payments. These are payments from individuals and households. So if you look at this graph, the green portion represents the aid, what portion of health spending comes from aid. And this is a graph of the top 20 aid recipients in Africa, the top 20. So obviously we expect aid to represent a big portion, but we also see the red bars, which represent private out-of-pocket spending. What Africa has done over the past many years is to try and reduce out-of-pocket spending, because a lot of that is, catastrophic, meaning that households basically need to sacrifice their livelihoods to spend on a health episode. So any health spending pushes households deeper and deeper into poverty, right? The blue bars represent public spending, the portion of health spending that comes from the public sector or the public purse. Now, bear in mind, what we seek to do is to minimize the red bars, but also minimize the green bars, because donations are donations. They cannot be sustainable. They depend on how the person wakes up, from which side of the bed the person slept, what the person ate, and in many other things. So as much as possible, when we talk about sustainability and financing of health in Africa, we are talking about expanding, even gradually, the blue bars and minimizing the red and the green bars, because both are really not sustainable. So bear in mind this is the context of what we want to discuss in terms of financing of Africa's health. Let us revisit the proportion of spending. And the question really is whether Africa is falling behind its own targets. So the Abuja Declaration is an African declaration. It's not a UN declaration. It's a declaration by the heads of state of Africa that going forward, and this is from the year 2001, each country was going to commit or had committed to spending at least 15% of their annual budgets on health. So 15%. Minimum 15% on that. Remember the first graph we showed that many of them are spending less than 7%. And indeed, if you track the Abuja Declaration, this graph is for 2020, where only South Africa met that target. But if you track the Abuja Declaration from 2001, we have not had up to 5 countries, between 3 and 5 countries, meeting that target per year. So, really, 24 years down the lane, we still have not been able to meet our own targets. Should we be revisiting the target as part of efforts to mobilize more and more domestic spending? Should we scrap the target, or should we find other ways of motivating ourselves or our countries to spend more on health? So this again is the context. This is what is happening in Africa. In Africa. In this slide, what I try to show is an analysis that we did comparing Africa to the rest of the world. And what we've done is to, track government spending for the year between 2000 and 2021, sorry. And then based on that scenario, project for the next 20-something years. So again, assuming that, things are, in the future, things would be how they have been, this is the situation. And the bars on my left, these bars, represent the general government spending as a share of GDP for Africa compared to other regions. So Africa represents the green, the deep green and light green bars, and other regions, the deep blue, light blue bars. So again, this is general government spending, So yes, there is a difference, or there are differences between the sub-regions of Africa and the rest of the world if you look at general government spending. But that difference is not as profound as comparing it to government spending on health as a share of GDP. So general government spending on one hand and government spending on health as a share of GDP. And this is what we see on this graph. So indeed, is Africa prioritizing health in its own spending? It doesn't look like we are doing. Could Africa prioritize health better going forward? And these are my views. Some of these views, appear or are corroborated by some of the data that we have. But again, before we delve into that, there are underlying problems. The issue, and I picked just one of them, debt servicing. This is a report by the UN. And clearly what the report says that many countries in Africa actually on an annual basis spend more servicing debts than they spend, financing the health of their populations. And, you can compare with other regions, but I'm focusing on Africa. The amount of money or the share of government spending that goes to paying for interest on debts is higher than, what goes into spending on health or even on education, even though we know that historically education's budget has been higher than health budget in many African countries. But here we are sacrificing the health of our people for servicing debts. And of course, you service debts. If you owe someone, you need to pay for it. But who do you owe? And how did that debt come about is a matter of discussions and the role that the multilateral system plays in debt sustainability and debt management leaves much to be desired. I said I was not going to go into this discussion, but I want to use this one slide to highlight arguments that we make in a paper that, of course, not just arguments, but arguments based on data from the Global Health Expenditure Database, that we reanalyzed. That indeed aid, wherever it comes from, may have actually contributed to undermining the formation of sustainable UHC financing in many countries. And that the current architecture is such that aid seems to be displacing domestic financing, right? In many countries, the fact that there is aid, and indeed this came up of many discussions we had, other Africa CDC and previous work, engaging with people from ministries of finance, people from ministries of health, it's clear that a lot of the work we do within our ministries of health, or it's clear that we have created, aid has created some dependence from ministries of health. And that dependence means that the country does not, finance as much as it could. Indeed, speaking with some directors of budgets in some countries, people would often say, your people in health, they behave like spoiled children because we give them some money. We know the money is not enough, but they don't come back to us because we know they always have aid there to help them. But far beyond crowding out domestic spending, aid has also contributed to crowding out of domestic leadership because many countries have ceded leadership and financing of their health sectors to donors and global health initiatives. And it is important that as we have discussions, we in Ghana we have an adage that says that as you advise the cat, not to chase the mouse and devour the mouse, you also need to be advising the mouse not to come in the way of the cat, right? As we focus on really addressing the question of how can our countries spend more themselves, we also need to have a conversation about how the DH architecture can work better for Africa and indeed for other lower and middle income countries. So coming back to Africa, are there options for Africa to step up and sustainably finance its own health? I present a few points here that we have raised in previous work. For, as a context, and I know that many people make the case that Africa cannot achieve the UHC without aid. And I strongly object to that context, that argument. As a context, the highest amount of aid Africa has received in total was in 2021 during COVID-19 pandemic. And this was $84 billion. Before then, aid had been somewhere between hovered around $40 billion. So 84 billion is the highest that had been seen. And so to make an argument that, those who spend $84 billion will need to somehow magically spend close to 371 billion to enable Africa successfully implement UHC leaves much to be desired. But there are options. For instance, in 2023, and this is a report by the World Bank, total value of remittances to Africa alone amounted to $54 billion. Now, the UN also estimates that the annual value of illicit financial flows, mainly, flows out of Africa through capital flights and other, moving of profits, things like that, amounts to about $88 billion. This is every year. Now, Africa also has a very huge untapped tax potential. And this is not, I'm not arguing for, taxing people more and more, but simply being efficient in our taxation and closing the loopholes in our tax systems. The average tax to GDP, ratio, which is the portion of GDP that comes from tax, for 36 African countries in 2022 was 16%. Now, if you compare this with Asia, the Asia Pacific of 19%, the Latin American Caribbean of 21.5%, even ensuring that we can close the tax loopholes and become a bit more efficient in collecting already existing tax policy, laws, or collection tax based on existing tax laws, we could significantly improve, the revenue that would then, of course, need to be prioritized, because improving revenue necessarily doesn't mean it will improve financing of health. It would need to take efforts, specific efforts, to ensure that we prioritize health in these spending. So there are options, and arguably, if we can close the loop on these various options, there is no reason why Africa cannot finance at least a large part of its own health. We know that there are countries that will continue to, require some aid, especially, those that are fragile and conflict affected. But by and large, there are also countries in Africa that could not just finance their own health, but actually support other African countries to finance their own health. And I don't want to mention examples here, but we know that if you look at the revenue potential of big countries, like South Africa, like Nigeria, I said I wouldn't, but I have. There's no reason why we cannot make a case to finance from domestic sources a lot of our own health. And we've seen some good examples coming up. Only last week, Nigeria announced some big funding to boost its health sector and to try close even a bit of the gap left by the US executive orders that have left very huge problems across the place. So there are examples and there are things that, countries can learn from, but we don't need to wait until we get to this stage. We don't need to be reactive to people pulling out. We can be more proactive in ensuring that we finance our health. Let me finish this presentation by looking at the other side of the question. So basically, the argument I've made in the first part is that, yes, given the current constraints, or even within the current constraints, Africa can still provide more money for its own health. But how, but what about the other part of the equation of more health for the money? More health for the money, in simple terms, includes ensuring that even the little funding we have now would be used in a way that optimizes health outcomes. And we've seen, a lot of work that has been done by many, many people to help improve efficiency in allocation of resources for health, within countries. A lot of that has been done, and I give a few examples of work that I have done with other colleagues. For example, on childhood vaccination. So whether it's malaria vaccine, rotavirus, HPV vaccine, these vaccines, there has been evidence that has supported either the introduction of these vaccines or the continuation of vaccination to ensure that we are comparing the inputs and the outputs and being efficient in the allocation of these resources. Indeed, during the COVID-19 pandemic, a lot of work was also done, especially led by the Africa CDC. And I might say that one of these, I think this particular article, you would see was led by Mark and Anna at the London School in support of the Africa CDC's work to ensure that the resources that were put into the vaccine efforts around the vaccines themselves, but also the treatments, that these decisions followed a very rigorous process of determining that they indeed present value for money. So a lot has been done, but we have a key challenge, and that challenge relates to sustaining the use of such evidence in decision-making, in strengthening institutional capacity to make decisions based on the evidence around the resource availability and the outcomes. And here, even though some efforts have been made to institutionalize priority setting within decision-making settings in Africa, there's still a lot more that needs to be done. Many countries do not have any explicit systematic way of allocating these resources beyond somebody sitting and deciding whether or not some amount of money or some resource should go somewhere. And there are a lot of factors, that that would that contribute to or that are important to ensure that we move from ad hoc decision-making processes to more institutionalized processes. We need a political will. We know that decision-making, usually does not have the time, and decision-making would require to blend with the pace of evidence gathering, evidence generation to inform those decisions. We also need political champions, as has been the case in many of the countries. The other big challenge has also been around limited capacity of country teams. And so we've seen a lot of the work done, for instance, around priority setting for Africa in many countries to have been outsourced to external TA providers and consultants. But in fact, just outsourcing that does not build country capacity. So it's important to blend and ensure that even if the country does not have capacity and some external person is brought in to support that decision-making process, we will have sustainability in mind, that the country capacity of suppliers within the country, but also capacity of people within the ministry to demand and absorb such evidence that comes would be built in the process. Again, the challenge of resourcing, it still goes with funding, but it's important for our ministries to understand that evidence for policy requires some resourcing that would help, whichever units of the ministries pull together and facilitate the generation of those pieces of evidence. Regional efforts are also very important, and it is crucial that as global players, whether as researchers or funders, we support such regional efforts. One of such efforts, is Africa CDC's leadership in developing not just a continental framework, but actually mobilizing, many of the countries to rally around evidence-informed decision-making or the use of evidence for decisions. The Africa CDC had developed that framework, and I remember at the validation of the framework, there were 44 out of 55 countries in Africa coming in and showing their interest to get supported. Now, that requires capacity, but that capacity needs to be facilitated in a way that ensures sustainability, which is why regional, facilitation, such as the role that the CDC plays, are very important. Let me finish off with this slide to provide a few reflections. The events of the past 2 weeks or so, I know, have led to panic within many quarters about what would happen to health in Africa. But I think these events, together with the COVID-19 pandemic, during which we saw, during which African countries really saw that they could not depend on the West, for instance, to buy vaccines. I think they present a very good wake-up call for Africa to take the ball in our own court. Africa has the capacity to allocate more than it currently does. Africa has the capacity to be more efficient than we currently do in allocating resources for health. Our countries need to urgently explore other options. I only mentioned 3 of those options, but I know there are many other options to urgently increase domestic resources. I did not mention the private sector, but the private sector presents another, opportunity to work with government to improve financing of health, raising the necessary private capital. Development banks, the Exim Bank, the African Development Bank, and the others also present a very, important approach to helping countries mobilize the needed capital. And I think we need to step up our game and engage with these different options rather than sitting and waiting for manna to fall from heaven. Because that manna can actually be cut off by someone else. Our countries need to urgently develop and strengthen our own institutions to promote evidence-informed priority setting. But I cannot end, without saying that the current landscape of donor financing needs to urgently realign with domestic funding, not crowd out domestic funding, to promote efficiency, effectiveness, and win-win situation for both the donor countries, but also for Africa, and ensure that Africa actually is in the driver's seat when it comes to determining its own priorities and putting funding on the table, before others would come in to support many things. And a lot has been written about how donors can better finance, for instance, R&D and all of that. We need to refocus as a continent, or as countries within the continent, to ensure that 5 years, 10 years, 20 years down the line, we do not continue to see very huge dependence on donor spending on private, on out-of-pocket expenses, but gradually we get our countries to put in more money. We've seen many countries institute health insurance schemes, which are great because they are an opportunity for the country to put tax funding into that. But of course, we need to ensure that such attempts do not only finance the curative health sector, but we also clearly build in strong funding for primary health care, for preventive care, to ensure that we close the gaps in equity and the other gaps within the health system. So let me stop there. Apologies for taking most of the time, but I'm sure there will be questions, and I'm happy to engage in any further questions. Over.
Great. Thank you so much, Justice. That was incredibly a huge big picture, and so I learned so much from it. And I really appreciate the way you presented not only the challenges that Africa faces in terms of health financing and improving health, but also you painted a very positive message as well, that there are challenges, but things can improve. They can be a more sustainable and more better way to work. So I'm going to open up for questions now. Please put your questions either in the chat box or I think there are two chat boxes, a Q&A or a chat. Ideally, you should use the Q&A, but I know there's some people posting in the chat, so I'll read those out first. Maybe I'll start off with the first question, and while maybe Justice, you answer that, other people feel free to add your questions. This is from Boniface Mubuthia, who says, Justice, great presentation. In your opinion, what conversations should we be holding now at the regional bodies such as the African Union, economic and regional blocs and national level post the changing financing landscape? By which I mean, I think he might mean the sort of reduction in overseas aid from the US, but I think not just the US, even in the last few years, we've seen reductions in aid from Europe, from Australia, although not so dramatically and precipitously as in the US. So over to you, Justice.
Yeah, thank you very much, Boniface. I think, so as I mentioned, we've had discussions. Discussions have come up around, improving domestic financing. And I think that's it. One can easily focus on aid and get completely thrown off. But that should not be our focus. Our focus is how can we even incrementally increase our own funding? So the ALM, for instance, the ALM is a very ambitious agenda, by the way, that is being implemented by the African Union Commission, by NEPAD, which is the African Union's development agency, and by the regional economic groups, SADC, ECOWAS, and the others. So some discussions happen, and every year, every February, when the heads of state meet, they are meeting this week, actually, in Addis. Reports are sent to them about, how countries are dealing with, financing, with a health financing track and stuff like that. Unfortunately, those discussions, in my opinion, are also mainly driven by external partners. I have been involved in those discussions, and I've pointed out that, you see, Africa has the resource, Africa has a human capacity, because we know our problems, and we should be able to define our problems well. We should be able to get our heads of state, to understand it. They do understand the problem, but just, reiterating what the problems are. But if we depend on donor organizations, by the way, some of whom have their own interests, to help us discuss or move discussions around domestic financing, then that becomes very unfortunate. And I think that what we need to do is to urgently, ensure that we refocus. And some of those discussions should move beyond mere discussions. They should move beyond reports. Because sometimes, reports are made and sent to the heads of states. They review the reports, they approve whatever it is, whether they are communicated or not. But the question is, how do countries actually move beyond that? And this is where the problem is. The capacity of countries, it involves a lot of building of capacity within the countries. And when people make the case that, for example, if you send money to ministers of finance in countries, or ministers of finance do not have the capacity to ramp up tax, I say help them strengthen capacity. Of 55 countries, yes. Can we do that gradually? We can. If it will take us 10, 20 years to mobilize ourselves, I think we have the opportunity to do this. So once we're able to move one step at a time each year, I'm sure we'll get to the point where aid would only become a top-up and not the base for us to depend on.
Great. Thank you so much. I would love to hear more about what you mentioned about building capacity, but I mean, there are a lot of great questions as well. So let me go to those. One from Peter Navarro. Can you speak a bit about the impact of HIPC? I think that's the heavily indebted poor country initiatives on health spending in qualifying countries. And if you could give an example of setting up a donor beneficiary win-win.
Yeah, HIPC, I remember when I was in school, HIPC was one of the big things in Ghana, because Ghana went HIPC, and some funds were, funding became, some debts became flexible spending for countries. Right now, we are talking about debt for health swaps. And, I know that the African Union has been vocal in that space, while at the CDC and part of the African Union's health working group for the G20. I know the G20 under the Brazilian leadership also was very big on exploring how debt for health swaps, where, countries, debtor countries like African countries that owed other countries that would seek for forgiveness and in return agree to use a certain portion of that to fund specific things. We've seen examples, for instance, in Egypt. I think Egypt negotiated a debt for health swaps with the Global Fund, and in return, they used that to finance some malaria efforts in Ethiopia and a few other countries. We see examples of those different things happening. But the challenge is that these things are also not sustainable because it means that I owe you, I cannot give you the money in return, use the money to pay for something else. We've seen resistance from the creditor countries because they believe that it is not efficient. But at least those are a stopgap measure to help countries improve more and more how much money they give. So as we allocate more money from debt for health swaps, we need to bear in mind that outside of the debt for health swaps arrangements, our countries themselves will begin to gradually put in money. Because once the debt for health swap arrangement ends, what happens to health? So yes, there are examples, but also it's important not to view this as permanent approaches to ensure that countries can finance their own health.
Great, thank you so much. There are lots of questions coming. Your talk has really sparked a lot of discussion. One from Emma Sachs. Do you think it's still useful to use percent GDP as a target for health expenditure, or is there a more valuable metric like percent of public spending or even absolute amount per capita?
Well, as I said, GDP is not a perfect measure. GDP has never been a perfect measure. I'm sure the system is still struggling to identify what the perfect measure is. But as long as it is used to represent how much government spend. So the Abuja target actually started not so much as GDP, but as a percentage of government's annual budget, right? So the total amount of how much the government wants to spend in a year, how much goes to health. So that's how it started, even though with time, the definition got caught up with GDP per capita. So because the budget is money that's available, of course, we know that part of that budget is also funded by donors. But the question is how much of the public's own funding goes into health? And for now, health systems, people are arguing that countries in Africa should begin to expand their tax funding, public finance health systems. So from the tax, what proportion of your tax actually goes into financing of your health? I think that would be a better measure, of course, because we do not want to see out-of-pocket payments go up. GDP also becomes too theoretical because it includes many things that may not really bring cash, right? So yeah, whichever measure we use, the important thing is to ensure that something tangible happens within the country.
Great, thanks. I mean, we've got lots of questions coming. We probably only have time for 2 or 3 more, but let me move to Amal Ali from Somaliland. He says, fantastic presentation, fascinating to learn. And he said, in Somaliland, a large proportion of GDP comes from remittances. So do you have any experience of African countries that have implemented a fee on remittances to support health?
Thanks, Amal. No, I cannot, off the top of my head say so. And I'm also careful when I talk about remittances because then people say, you put, you are asking your governments to put some, to tax remittances more and more. But I think there are opportunities there. I mean, let's be frank, for those of us who are in the diaspora, right, we do send a lot of money home. If there were mechanisms to say we could actually use a portion or pay additional charge on the remittance that will finance the health, say health insurance, because that's what people feel, the most. If I were outside of Africa and I'm told that I want to send $50 to my mother, whenever I send $50 to her, can I add $1 or can I add $2? So that those $2 will be used to provide my mother direct health insurance. I believe I would be willing to do that, right? But if I'm simply told that, oh, I would pay 5% of that tax that will go to government to do some work, that is where, people do not necessarily trust so much the public system. And I see someone has talked about corruption. Yes, there is corruption. Yes, there are other ways that siphon from the system. And so the system itself will need to be trustworthy so that people can understand. But I also think that the way we communicate such measures is also very important, so that people would clearly be able to understand. One of the things that the new DG of Africa CDC came up with initially was airline levy. So the job for some of us had to be convincing, many people to add a few more dollars to airline tickets to pay for them. And I remember having a conversation with the economic advisor to heads of states. And I asked one of them, will you be willing to pay an additional tax if it funds health in your country? The person says, well, it depends. I said, okay, if you have a ticket worth £1,000 and at the point of payment, they said, add £1. If you add £1 to that £1, maybe 50% of that £1 will go to financing a specific health whatever in your country. The other 50% will go to Africa CDC to help build the health security infrastructure. Would you be willing to do that? I said, well, £1, yeah, that's not a lot of money. So the way we communicate these things would also be very important. And I think that what we haven't done well is not communicating well, because people do not trust the system so much. And that's work we need to do.
Great, thank you. There was, as you pointed out, there's that point made by Kellen and Musisi about corruption, but I think you've addressed that. So I'm going to go on to the next question from Claude Kasonka, who pointed out that actually we need to find ways of finding efficiencies in procurement and PFM systems. It's a huge cost in health. So what are your thoughts in, using procurement as a center for discussion to create savings?
Yeah, Claude, thanks. I think you are spot on. The inefficiencies in the sector, like I said, we can significantly improve, the way we use the current money that we have, through plugging the loopholes in the PFM, public financial management systems, in procurement. We know in many countries, procurement really breeds a lot of the corruption issues, right? How can we ensure that people account in a very transparent manner what they use the resources for and are willing to defend it? But also, how do we put people to task if they do not spend these resources well? So those are different ways of closing the loopholes so that we can make the best use of the current resources. And I see we are out of time, but I see a question around the Africa CDC. I'm not sure. Should they remain loyal to a world body like Africa CDC or not? What role do you see these hierarchies? I am a firm believer that regional institutions are very important, because if you leave this to countries, they will focus on within country challenges. But there are challenges across countries. Mpox is not a challenge for just one country. It's a challenge that requires cross-border surveillance, that requires kicking in of cross-border mechanisms. WHO, Africa CDC are equally important in that task. Each of them play a key role, and I think the challenge has been getting to ensure that people see them as complementary and not necessarily substitute organization. They equally play a very important role, and the countries understand this. This is why they remain loyal to both Africa CDC and the WHO. The way we take advantage of these regional organizations to improve health on the continent would be where we need to focus. Thank you.
Great. Thank you so much. Now, if people can stay on just a few minutes, Shivani just pointed out there's someone who's had their hand up for a while. So Shivani, do you want to unmute them so that they can ask the question? Maybe that's the final question.
Oh, thank you very much. I'm Dr. Patricia and I'm from Uganda. I posted my question in the question bank and he answered it. Thank you.
Okay, that's brilliant. Well, I mean, we're at 10 o'clock. I feel there's so much more we can learn from you, Justice, but we've reached that time. So thank you so much. I'm sure people would love to have more conversations with you. Maybe some of them might be contacting you in the future, but it's really an honor to have African health leader like you join our forum. So thank you for joining us, and we hope we can continue this collaboration and communication. And thank you everyone for coming. It's been great to have you as part of this conversation.
Thank you so much.
Thank you.
Thank you.